cannot forget my headset to the office.
The moderator. Carry that. I'm tired. Okay.
Oh, iya, Zoom. Bisa. Oh,
Good evening, sir. Thank you for joining us. We start soon. Give us about 7 minutes to put it into place for others to also join. So we start as soon as possible. Thank you very much. Good evening, sir. Thank you for joining us. We start soon. Give us about 7 minutes to put it.
Prize. Now, nigga, this is called leverage.
Yes, thank you very much. I think you can start now. Yes, so that we can do the preambles. Yes, thank you.
Good evening, everybody. My name is Dr. Wanko. I will be functioning as the moderator for today's presentation. I'm a senior registrar from Family Medicine, LASUTH. So I'll be moderating this presentation. So Dr. Luatu, a consultant family physician at Lagos State University Teaching Hospital, will be presenting hypertension in older adults. Please, am I audible?
Yes, you're audible. Can hear you.
Thank you. Okay, thank you so much. So while we're waiting for others to join, I am going to read Dr. Luati's citation while we are waiting.
It's not 8 o'clock yet at my end. Maybe we should still give it a minute to 8 before we start.
Okay, all right.
What does
I should.
Good evening again, colleagues. Good evening to the consultants, senior registrars, medical officers, ladies and gentlemen, all protocols duly and well observed. So today we're going to have a discussion, a presentation by Dr. Luati. So Dr. Luati will be presenting hypertension in the older adults. Hypertension in the old age. So I'm going to go ahead now and read Dr. Luati's citation before we start the presentation. Dr. Luati Olamide Esther is a family medicine specialist. She's a fellow of the West African College of Physicians. She's based in Lagos. She has extensive experience in the healthcare sector with a focus on providing patient-centered care, particularly for older adults. She has functioned in various roles. She has worked as a part-time consultant family physician at Evercare Hospital. She's a full-fledged consultant at the Family Medicine Department, Lagos State University Teaching Hospital, LASU. Her expertise spans the care and management of older persons, also management of chronic medical conditions, lifestyle-related diseases, and the provision of multidisciplinary care for patients with multimorbidity. Dr. Luati holds a medical degree from Igbinedion University and is actively involved in research. She has authored and co-authored several publications, including studies on older adults, diabetes management, hypertension, and the impact of social support on glycemic control. She has also contributed to the advancement of family medicine through mentorship and training of residents. She's particularly passionate with the training of residents. She has earned several professional certifications, which includes Certificate Diploma in Geriatric Medicine, CPD Series 2021 from the South African Geriatric Society, Basic Certification in Geriatric Medicine from the University College Hospital, Ibadan 2022, Leadership and Management in Health and Global Mental Health, both from the University of Washington. She has to accredit other certification from the American Heart Association, American Safety and Health Institute, certification from BVGH in palliative care, amongst others. In addition to her clinical and academic work, Dr. Luati is committed to community service, having led various health outreach programs, particularly for older adults, and a member of numerous medical organizations. Her leadership extends to administrative roles, including positions as current Deputy Residency Training Coordinator, Family Medicine Department, LASU, past Deputy Chief Registrar, past Financial Secretary, LASU ARD, Treasurer of the ARD, past Treasurer of the ARD, Cooperative Society, and Secretary. She's also an advocate for medical ethics and the rights of patients. So I rest my case now. So I'll be introducing Dr. Luati to commence her presentation. So Ma, you have the floor.
Thank you so much. But Dr. Ladunjoye, am I still the host? Like my screen sharing is paused.
Your screen is trying to load. That's what I can see here.
Yeah, still the co-host, yes. can share.
I'm being told my screen sharing is paused.
Oh, really? Why? Okay. Oh, sorry. Try now. What of now?
Nothing.
Okay, you can try now. Should go.
Okay, while we are waiting for her screen, the slides to load, I would like to recognize the presence of Professor Bolari Temitayo Adebimpe. You're welcome. I would also like to recognize the presence of our chief trainer, Dr. Blessing Chukukelu. You're welcome, ma.
Oh. Dr. Wati, is it sharing now, ma?
It's, I shared just now.
Okay. Please bear with us a little. This,
Would you like someone else to share your slide for
I
you,
think
ma?
she logged out.
Okay.
Let's just hold on.
Sals and Mas, just bear with us. The presenter is trying to load her slides, to upload her slides so that we can see. She had to log out to log in again. So just give some few minutes to sort out technical issues. Thank you. Welcome everybody once again to today's presentation. We're still trying to get the presenter to load her slides, so just bear with us. She will be with us shortly. Good evening once again. Still standing on the existing protocol. So our presenter is trying to log back in. She was logged out. So we just give her a few minutes and then we'll be starting very soon. Thank you.
Yeah, Kale. Yeah, báwo ni nǹkan? Oh, okay.
Dr. Balasa, your mic is on, sir. Thank you.
Yeah, welcome, ma.
Thank you so much. I'm so sorry. One of the benefits of the internet, my system just suddenly froze. So I'm having to use my phone right now.
Okay, thank you.
Okay. So sorry everyone for the break in transmission. So as Dr. Nwako has generously introduced me, I'm Dr. Oluwatui, and I'm going to be presenting the topic hypertension in older adults. So, under the following outline, I'm going to be presenting under the following outlines. I'll just move on. So, as a way of introduction, hypertension, also known as high blood pressure, is a long-term medical condition in which the blood pressure in the arteries is persistently elevated. Hypertension is the leading modifiable risk factor for cardiovascular events and mortality in the world. Now coming to the older adults, hypertension is a major risk factor for cardiovascular events and mortality in the elderly. Even for those elderly that have heart-healthy habits, they can't help their arteries from stiffening. And at the end of the day, they may or may not develop hypertension. It's something that comes with the age that the arteries will stiffen.
Sorry, ma. Several people, their mics are on. Dr. Osho, your mic is on, please.
Dr.
Can we mute our mics?
Can you help
while
us
we listen?
mute them?
Please, ma, you can go ahead.
Okay, so the global prevalence of hypertension in people aged 30 to 79 years was estimated at the level of 1.27 billion as far back as 2019, which corresponds to 32% of women globally who had hypertension and 34% of men. This number will continue to grow with the aging of our population. As we know, people are living longer now and being exposed to chronic medical conditions. Approximately 60% of the population has hypertension. And by 60 years of age, has hypertension by 60 years of age. And about 65% of men and 75% of women develop high blood pressure by 70 years. So some people may safely say that hypertension is a disease of the
Wale.
old age. So, as with many conditions, hypertension increases with age, with its prevalence increasing from 27% in patients aged younger than 60 years to 74% in those aged older than 80 years. The Framingham Heart Study showed that more than 90% of the participants with a normal blood pressure at age 55 years eventually develop hypertension. That's 90% eventually developed hypertension. That's a large number. The estimated prevalence of, now coming down to Africa, the estimated prevalence of hypertension in Africa is around 30.8%. And in sub-Saharan Africa, it is between 30 to 31.1%. From a systematic analysis, the age-adjusted prevalence of hypertension in Nigeria increased from 8.6% in 1995 to 32.5% in 2020. In a cross-sectional study, 44.7% of the elderly in Osun State, Nigeria, had hypertension. So you see where we are coming from. About 30% roughly in the general population. But in older adults, using Osun State as a case study, we have 44.7%, which is way higher than in the general population. So, what are the risk factors for development of hypertension in older adults? Risk factors for hypertension in older adults include age, unhealthy diet, being overweight, lack of physical activity. Other risk factors include family history, those people that have a family history of hypertension, their race, especially in the Black race, tobacco use, those that smoke, alcohol consumption, unhealthy diet, physical inactivity, sleep apnea, high cholesterol, diabetes, kidney disease. All these are risk factors for the development of hypertension, especially in older adults. So, pathogenesis. Because I know that the population of people listening to me, some are health workers, some are not. I would crave the indulgence of those older adults who I know have joined this meeting that are not health workers to just bear with us when we take this pathogenesis, because it might sound like highfalutin stuffs, but I'll just quickly gloss over it because of those that are not medically inclined, and those that are might want to hear about the pathogenesis of hypertension in older adults. So the most important one is the arterial stiffness, which everybody knows that happens with age. Blood vessels lose its elasticity and it becomes stiffer, which would increase blood pressure. Increased peripheral vascular resistance is also an pathogenesis for development of hypertension. Renal function, kidney function declines with age, and this can also lead to high blood pressure. Endothelial dysfunction, the endothelium that lines the blood vessels becomes less efficient as people grow older. Then neurohormonal changes, insulin resistance, and metabolic changes, all this happens with age and predisposes older adults to developing hypertension. Inflammation and oxidative stress, lifestyle factors, especially poor lifestyle causes, physical inactivity, sedentary lifestyle, obesity, all these things become prevalent as people age because they are retired, they tend to sit a lot, they don't have much to do, they just sit down, read the papers or sit down with the TV, and so they are more predisposed to developing high blood pressure because of physical inactivity. And so that's why we encourage our older adults to please, even after retirement, they should still do something. It might not be something stressful, but they can move around, do regular moderate intensity exercises, which we are still going to talk about in this presentation today, that will reduce your sitting down or lying down or sleeping all day. Genetic predisposition like family history, comorbidities, especially those that have comorbid illnesses like diabetes and kidney disease, they can easily develop hypertension. So this is the ESC guideline. They put together this diagram. to show all the risks associated with hypertension. I've mentioned most of them, but worthy of note, what I want us to look at is the one below. The social, economic, and psychological factors: stress, low socioeconomic status, social deprivation, healthcare, that's problems with healthcare access, and gender identity. All these things, they sound far-fetched, but they have been seen and known as risk factors to developing hypertension. So what are the types of hypertension? We have primary and secondary. 90 to 95% of people have the primary hypertension. And there is really no known cause for these ones, for this cause of high blood pressure. Unlike the secondary hypertension, which 5 to 10% of people have, there is a known cause. And most of the time, when the cause is found and treated, the person gets better, blood pressure goes down. But like I said, most people, especially in older adults, have what we call the primary or essential hypertension. So what are the secondary causes? Like I said, 5 to 10% have secondary causes. These are some of the common secondary causes of hypertension. We'll not dwell on it since most of our older adults have the primary cause of hypertension. The clinical presentation of hypertension. Hypertension presents basically without symptoms, and that's what we call asymptomatic, and that's why we call hypertension a silent killer. The person is just going around with a blood pressure of 180, 120 and does not feel a thing. I've had a patient say, but doctor, I feel so very fine. Why are you saying I have to take drugs? I'm like, this blood pressure is so high, you can practically just drop down walking on the street. But the person doesn't feel anything. And majorly, that's the symptom, asymptomatic. And some people present when it is even already advanced. The symptoms they are presenting with are symptoms of complications, not just symptoms like, okay, I have headache. They are already presenting with difficulty breathing. They are presenting with blurry vision. That means that started to affect their eyes. They are presenting with nosebleeds, epistaxis, when the nose starts bleeding because the vessels are beginning to rupture because of the very high blood pressure. So other symptoms like nausea, vomiting, which can be symptoms of complications, anxiety, confusions, when you have encephalopathy, buzzing in the ear, tinnitus. These are some of the common presentation of those with hypertension. So classification of hypertension. Over the years, you can see in this slide, I've put the ACC and AHA source for classification of hypertension, which was as far back as 2017. Then the ESC, ESH, that's the European Society of Cardiology and the European Society of Hypertension. They had their last classification before the 2024 classification in 2018. And this was how they classified hypertension. The essence of this classification is to make you know when to treat. Because if you do not classify the blood pressure, you don't know where you fall into. You just feel as if, okay, my blood pressure is 150/90. So what? So that is why blood pressure is classified, so that you know where you fit into, when you need to treat, and also how you need to treat. Because depending on how high the blood pressure is, you may not just want to treat with drugs. You might need to admit the person to be able to bring down that blood pressure. So I will not dwell on this as well, because we have a more recent classification of hypertension, which I feel is worthy for us to look through today. But it is necessary for us to know that this was how it was previously classified, even as recently as 2018. So the 2024 ESC guidelines, which is actually the most recent guideline for the classification of hypertension, defines hypertension as office systolic blood pressure of 140 millimeters of mercury or diastolic blood pressure of greater than 90 millimeters of mercury. However, a new blood pressure category, elevated blood pressure, has been introduced. We saw the previous ones that was talking about normal, elevated blood pressure, stage 1, stage 2, isolated systolic hypertension, and in the ESC classification, they even had grade 3. But now, the most recent one, we don't have those stages again. And there's a reason why the classification changed. So I want us to listen carefully why the classification changed. Like I said, there's a new classification that is called elevated blood pressure. So we have non-elevated blood pressure, elevated blood pressure, and hypertension. Those are the 3 classifications of hypertension now. That's because those that have non-elevated blood pressure, no risk at all, they are fine. There's no problem. You just tell them to regularly do their annual medical check and check their blood pressure. But those that have elevated blood pressure, meanwhile, elevated blood pressure now, according to the 2024 ESC guidelines, and it is worthy of note that the ESC guidelines was produced after careful consideration of the scientific and medical knowledge and the evidence available. So the guideline has summarized available evidence. So this is not just based on some group of people just sitting together. They summarized available evidence to be able to come up with this classification. So elevated blood pressure is defined as an office systolic blood pressure of 120 to 139. And somebody will say, why? But after all, ACC people too defined blood pressure as greater than 130/80 as far back as 2017. So this shouldn't be so surprising. But what is interesting about this is that at blood pressure of systolic blood pressure of 120 to 139 and diastolic blood pressure of 70 to 89, you are classified as having elevated blood pressure. But then we do not go ahead to treat everybody with elevated blood pressure according to this classification. Only those with risk factors at this point, when their blood pressure is between 120, systolic blood pressure is between 120 and 139, they are the ones that we will treat. And what are those risk factors that they may have that would want us to treat them? Those with moderate to severe CKD, that's people that have eGFR less than 60, those with established clinical CVD, like those with heart failure, peripheral artery disease, coronary heart disease, those with hypertension-mediated organ damage, diabetics, and those with familial hypercholesterolemia. Also, what is important for us, especially for us clinicians, is that we should be able to assess our patients based on their risk. And we can do this by using cardiovascular risk calculators. Although the 2024 ESC guidelines says we should use the SCORE OP, that's the systematic coronary risk evaluation for older persons to assess their risk. And if they have a risk of greater than 10%, that means you want to treat this person, even though blood pressure is between 120 and 139. If this person is diabetic, you still want to treat. If the person has the hypertension-mediated organ damage, you want to treat. The patient has moderate to severe CKD, you want to treat. But those that don't have risk factors, even though they have blood pressure of 120 to 139, what are we going to do? We'll counsel them on lifestyle changes, which we are still going to talk about as we move on in the presentation. So it is not everybody that we are going to treat, especially older adults. The guideline still says blood pressure, hypertension definition is 140/90. But then, if there are risk factors, you treat at 130. So how do we measure blood pressure? The diagnosis of hypertension requires measurement of blood pressure in the proper environment. Safe, conducive environment, not hot, uncomfortable, noisy. No, the patient has to be comfortable. It requires that the patient be relaxed in a chair for at least 5 minutes with the arm resting. So it's not that the patient is just coming down from jumping a bus and running to catch a bus, and immediately the patient comes to say, sit down, let me check your blood pressure. No, that person has to relax. At least 5 minutes before you want to check the blood pressure. In order to establish diagnosis, greater than 2 readings of elevated blood pressure on greater than or equal to 2 occasions are needed. So the patient comes today, blood pressure is elevated, but not as elevated as being severely elevated to 180 over 120, but say elevated as 150, 90. You want to do a second reading on another occasion to ensure that actually this patient is hypertensive. Bearing in mind that we have a condition called white coat hypertension. White coat hypertension is more common among elderly people. I get a lot of elderly patients that say, it's only when I come to the hospital, my blood pressure is high. At home, my blood pressure is fine. I get 130, I get 120. But once I come to the hospital, it's 150 or 160. So white coat hypertension occurs majorly among elderly people. Younger people also have it, but a lot of our elderly patients have white coat hypertension. So this has brought about the need for ambulatory or out-of-office blood pressure readings, which is important in patients with mildly elevated in-office blood pressure readings. So their ambulatory blood pressure monitor, that the patient carries around for 24 hours, or the patient can check their blood pressure on their own at home and record it, and then come to show you in the clinic. And then you can make your judgment as a clinician. And so also for patients, most of the times when patients come to the clinic, we always tell them, please check your blood pressure at home. Keep a blood pressure chart so that we can assess your blood pressure more objectively. So these are pictures of what the blood pressure apparatus looks like. Oh, my slides were not changing. Sorry about that. So these are what the blood pressure apparatus looks like. The tables fig, which is debatable about it being the most effective way of assessing blood pressure. Some people say it's not objective because it's user dependent. Someone can check it now and say, I got 140/90. Somebody will say, I got 140/70. And so the use of the digital figs are gaining more ground these days. So what are the complications of hypertension? Like I mentioned earlier, there are symptoms that are already complications, and yet there are complications. Complications like cardiovascular disease, stroke, chronic kidney disease, cognitive decline, and dementia. Most people with hypertension, especially uncontrolled hypertension, are the ones that develop cognitive decline and eventually dementia, vision loss, peripheral arterial disease, sexual dysfunction. We get a lot of that complaint in the clinic. And once you already start having these symptoms, these features, they are already features of complications. So in individuals with increased CVD risk, where their screening office BP is 120 to 139 or over 70 to 89 millimeters of mercury, it is recommended to measure BP out of office using the ambulatory blood pressure monitor or the home blood pressure monitor, which I mentioned earlier. Or if that's not feasible, you can make repeated office blood pressure measurements on more than one visit. So what is ambulatory blood pressure monitoring? I already spoke about it earlier. You measure your blood pressure over 24 hours. The person carries the blood pressure machine. It's the ambulatory type. You can wear it over your clothes. You can wear it under your jacket and you go around and the blood pressure keeps reading at intervals. Sometimes these things are digitalized that even your physician or your care provider can see those readings as well. Or you come back and drop the machine and they go over the readings that you've had over 24 hours. And then we can objectively assess, okay, this person is actually hypertensive, or no, it was just white coat hypertension. So what's it used for? It's used for diagnosing high blood pressure, identifying patients who have high blood pressure readings in the clinic. That's the white coat effect. Helping to decide if blood pressure medication is needed. Like I said, especially now that we have the target blood pressure has reduced, you don't want to go ahead to start treating everybody. So you need to be sure that this patient is really hypertensive and this patient actually needs treatment in order to go ahead with your treatment, helping to decide if any change to your medication is needed. So this is a picture of what the ambulatory blood pressure monitor is. I know it's not so common right now, but I know we have some in some diagnostic centers, in some physiologic lab, they have some of this ambulatory blood pressure monitor, and it has been proven to be really helpful. But for those of us that don't have, please, we can still do our home monitoring of our blood pressure. So what is another entity I want us to look at, which is common among older adults, is isolated systolic hypertension. Isolated systolic hypertension is when the systolic blood pressure, that's the up blood pressure, is more than 140, and the diastolic is less than 90. You know, we've said that hypertension, even according to the ESC guideline, the latest guideline, is when blood pressure is more than 140 over 90. But here in isolated systolic, we're now saying the top one, which is the systolic blood pressure, is greater than 140. And the lower one, which is supposed to be greater than 90, is now less than 90. So you see blood pressure like 140 over 70. And for those of us that see older adults, you agree with me that you see a lot of this in the clinic. It is the common form of high blood pressure in older adults and can lead to serious health problems. I know sometimes when people see isolated systolic hypertension, they're reluctant about treating because they're like, if I treat this person now, this person might go into hypertension. There is usually this inertia about treating isolated systolic hypertension. But isolated systolic hypertension also has its own complication, especially when the systolic blood pressure is way higher than 140 or 150. So sometimes we still have to treat, but of course, we'll still talk about when and when not to treat, especially in our older adults who are the focus of today's conversation. So it is the most common form of high blood pressure in older adults and can lead to serious health problems in addition to shortness of breath during light physical activity, lightheadedness upon standing too fast, and also falls. So people with isolated systolic hypertension, they are predisposed to things like this. Treatment is actually recommended to avoid complications in them. Another thing I want us to look at that is common among older adults is orthostatic hypotension. So what is orthostatic hypotension? It is a significant drop in blood pressure when standing up from a sitting or lying position. The blood pressure change is greater than 20 for the up blood pressure, that's the systolic blood pressure, and greater than 10 for the lower blood pressure. So you will check the blood pressure 1 minute after standing up and 3 minutes after standing up to be able to detect if this patient really does have orthostatic hypotension. Because patients with orthostatic hypotension, they are the ones that, especially older adults, I'm feeling dizzy, I'm feeling lightheaded, especially when they get up from a sitting position or when they get up from a lying down position. They have these symptoms. Please, let's think orthostatic hypotension. And for patients too, you can, when you feel things like this, you can actually self-care and check your blood pressure yourself and let your clinician know what you have gotten when you have documented your readings. So orthostatic hypotension is more common in older adults. It carries the prevalence of 18% and it's associated with increased falls. That's why you hear a lot of older adults. Falls, very common. And so we have to assess risk for falls in them. Part of the assessment is to check for orthostatic hypotension. So some of the causes are age-related physiological changes like medications. Medications like diuretics, like our alpha blockers, our men on tamsulosin, and some of these anticonvulsant medications that we use to treat neuropathic pains. They have been highly implicated in the cause of orthostatic hypotension. Dehydration and electrolyte imbalances, chronic conditions like diabetes, Parkinson's disease, a lot of them have orthostatic hypotension, autonomic dysfunctions, and I already talked about the symptoms of those with orthostatic hypotension. So those with orthostatic hypotension, what do we want to do for them? We have the non-pharmacological and the pharmacological treatment. Non-pharmacological is just when we don't use drugs to treat. Pharmacological is when we use drugs to treat. In my own practice, I've really not had any reason to use pharmacological treatment, that's drug treatment, to treat orthostatic hypotension. Most of the time, we do the non-pharmacological treatments, and a lot of times it works. So for them, we'll say that they increase their fluid intake. They should gradually change their position. They should not just stand up very fast from a sitting position or from a lying down position. I mean, you are a senior citizen, so get up gently. I know some people find it difficult. They've been so agile and active all the while, and all of a sudden now you're telling them to take it easy. Yes, please. Now that you are a senior citizen, you have to take it easy. So compression stockings also helps to improve circulation. Physical activity improves blood flow and muscle tone. Also, we tell them to elevate the head of their bed at night to reduce overnight drops in blood pressure. And for physicians, these are the medications that are used in treatment of orthostatic hypotension if we do need to treat. However, something else that we can do is to adjust the medications. We know the medications that would really cause orthostatic hypotension. I mentioned them, especially for patients that are hypertensive, our diuretic, alpha blockers, beta blockers. These are notorious for causing orthostatic hypotension. And we have our patients on this. You may want to switch the medications a little. ARBs are very, very conducive. They do not cause orthostatic hypotension. So if the patient is not already on ARBs, you might want to switch ARBs and possibly add your calcium channel blockers, which would help stabilize the patient in addition to the non-pharmacological approaches, rather than going to use the drug treatments. So the management of hypertension. Before we start treating hypertension with drugs, there are things that we can do to ensure that we bring down blood pressure, especially when the blood pressure is not yet up to the target for treatment. When we have those that have systolic blood pressure of between 120 and 139, you want to introduce your lifestyle changes. Even for those that have above 140/90, they should still take part in the lifestyle changes. And after few weeks of trying the lifestyle changes and we are not getting a change, then we can go for the pharmacological treatment. So what are these lifestyle changes? The DASH diet. DASH diet is the dietary approach to stopping hypertension. So when we say DASH diet, many people just think of salt, that, okay, we just reduce salt. Yes, we're supposed to reduce salt. We are supposed to reduce our sodium to about 1,500 to 2,003 milligrams per day. Someone will ask, how does that help me in my kitchen? So a table teaspoon for one person per day. So by the time you calculate your pot of soup, and I always encourage those that are hypertensive, instead of having a separate pot, let everybody in the house eat from that same pot. After all, everybody in the house is related to you, and they are also at risk of developing hypertension. Let us train our taste buds from the very beginning on reducing salt in our food. Other things that are a part of the DASH diet is increased fruits and vegetable intake, increasing our whole grains intake like our oats, whole bread, and brown rice. Also lean proteins like our plant-based proteins, beans, lentils, and nuts. All these are part of the DASH diet and not just the salt. Regular physical exercise, moderate intensity exercise, 150 minutes weekly, span of 5 to 7 days. For older adults, we are talking about older adults. So if you do 30 minutes every day, Monday to Friday, you would have done 150 minutes in a week. So even when you have arthritis, even when you have lumbar spondylosis, it does not stop you from doing your moderate intensity exercise, your daily exercise. Talk to your doctor. We have ways of going about it. We can tell you to get knee brace. We can tell you to get lumbar corset. We use topical analgesia. And if needed, we go for the oral analgesias. to help you so that you can continue that moderate intensity exercise. Like I always joke with my patients that if you do your moderate intensity exercise, you will not grow old on time. Even if the mama is 85 years old, I will say so that you will not grow old on time. Please, let's do the moderate intensity exercise. It's very essential. Limiting alcohol intake. Very, very important. I know some people will argue, and there is a level of alcohol that you should drink. Even the ESC guidelines, despite the fact that they said less than 100 grams per week. I don't know how they want to measure the 100 grams. At the end of their statements as regards alcohol, they said it is recommended to avoid alcohol to achieve the best health outcome. I know they don't want to open their mouth to say, oh, that don't take alcohol. However, some people have done so. In 2022, the WHO published that there was no safe amount of alcohol that does not affect health. And they still reiterated it in 2024. And they said even moderate drinkers, they have increased risk of developing cancers and cardiovascular disease. So for those of us that want to hide on that guidelines, even guidelines have started to deny people now. So I will still put it at limiting alcohol intake, but at the back of your mind, let's know that there is no safe level of alcohol. Smoking cessation. Very important. So going to the drug treatment of hypertension, we've talked about lifestyle. The first step for patients that you have decided to treat, maybe they have blood pressure of 140/90, greater than 140/90, or they are between the 120 to 139 mark, and they have risk factors that we have mentioned earlier, and you have decided to treat them. Depending on what the blood pressure is, you might want to start with monotherapy. That's one drug. The first line drugs are the calcium channel blockers, like our amlodipine, ifedipine. You might want to start with that. If you need to use a combination, you can combine with your ARBS inhibitors, that's your losartan, lisinopril, valsartan, candesartan, all the TANs and the prils. You can combine them. That's in step 2. Step 3, if the blood pressure is still not controlled, you might want to add your low dose diuretic. And we have to be careful with the diuretic in our older adults. Like we said earlier, older adults are more at risk of developing orthostatic hypotension, and diuretic is largely implicated in orthostatic hypotension. So you want to make your diuretic low dose if you must add. And even after adding, patient is still not getting the target blood pressure that we want. You may need to add more medications. At this point, we now say the patient has resistant hypertension. And medications that we can add include spironolactone. After these first 3 steps, we can add spironolactone or eplerenone if patient is not tolerating the spironolactone. We can also add beta blockers if it's not already indicated, if the patient is not yet on beta blockers. This is for physicians. Now, I'm talking to the physicians now because I know there are physicians on this call. We can add our centrally acting. If we have resistant hypertension, we can add centrally acting or alpha blockers. That's getting to the extreme. And these days, there are interventions that our interventional radiologists do. They do this catheter-based renal denervation that they use for patients with resistant hypertension. So these are a list of drugs that, or classes of drugs that we can add to treat resistant hypertension. However, the first line is the calcium channel blocker or your ARBs or your low dose diuretic before you start thinking of adding your spironolactone, your beta blockers, or your centrally acting, or your alpha blockers. The alpha blockers is particularly better in resistant hypertension for men who have BPH, that's benign prostatic hyperplasia. So the alpha blocker will help with their prostatic symptoms and also help with the blood pressure. So treatment of hypertension in older adults. Before now, there has been so many talks about treating hypertension in older adults, especially those that have isolated systolic hypertension, because that is the common form of hypertension that they have. Several studies have focused on guiding screening and management of hypertension traditionally, and they excluded older adults in all their studies and trials, particularly those over the age of 80. We have so many patients over the age of 80 in my clinic. So how do we know how to go about their management and treatment if we keep excluding them from trials? So because of this, treating elevated blood pressure in older adults in the past was very controversial. However, recent data, you may say that it's not so recent, has emanated that has demonstrated cardiovascular benefits in treating hypertension in older adults. Several key studies, including the UKPDS, the systolic hypertension in the elderly, that's the SHEP trial was as far back as 1985. At the end of their trial, they said that those with isolated systolic hypertension would benefit from treatment as it reduced all their cardiovascular risk. Also, the SPRINT study, the SPRINT one is even more recent. The SPRINT study happened in 2018, and those ones even reduced their target blood pressure to like 120/80 for older adults, because SPRINT is systolic blood pressure intervention trial, and there is SPRINT in older persons. There are other trials too that have shown that treating hypertension in older adults gives cardiovascular benefits. So if we are still in the school of thought that because the person is old, though, we should not treat the blood pressure, let's just leave the person. No, that's not true. Of course, there are things we need to consider when we want to treat. You see that target of 120 to 129 that we said we should use for patients that are on blood pressure medications. For those people that have orthostatic hypertension prior to that, those that are 85 years and above, those that have moderate to severe frailty, or those that have limited life expectancy, like life expectancy is less than 3 years, you don't want to be that strict with their blood pressure targets. So you can be strict, somebody can be 80 years old without all those risk factors, and you might still want to be strict and keep the person's blood pressure, systolic blood pressure, to between 120 to 129. But when there is orthostatic hypotension, when the person is older than 85 years, it's better to use targets of 140/90 as treatment targets, not diagnostic targets, as treatment targets. And those that are frail, you don't want to push them down more. They're already frail. So you don't want to be using a target of 120 to 129, even as the guideline says. Even these exceptions I'm saying are still exceptions from the recent 2024 ESC guidelines. So this slide is showing different, more recent trials about hypertension in older adults. And at the end of their trial, they found that all-cause mortality reduced and major adverse cardiovascular events also reduced. We'll see the IBET trial, JATOS, Valley, SPRINT Senior, the STEP trial. All these have proven. These are all randomized controlled trials, and they are landmark studies that have shown that there's benefits in treating blood pressure and reducing blood pressure to targets, although many of them had their different targets, as we can see. And the lowest one is the one from the SPRINT people, that when blood pressure was reduced to as low as 120/80 for older adults, they had fewer cardiovascular events. So I just thought we should know this. These are other trials, even the one from our parents' organization, the American Association of Family Physicians. At the time they did theirs, their targets for those greater than 60 years was 150. Their systolic blood pressure target was 150 millimeters of mercury, but that was as far back as 2017. Now we are talking of more recent studies, as recent as 2024, from the ESC guideline that is saying 140/90 as hypertension, elevated blood pressure as between 120 to 139, but you only treat those that have risk factors for cardiovascular disease. Okay. These are the more recent studies from the ESH. In 2023, they were still doing 140, but in 2024, the music has changed. Even NICE guideline was still doing 150/80 for those greater than 150/90 for those greater than 80 years, and all that we have seen from this table. So, blood pressure treatment target in older adults. I already talked about this. According to the 2024 European Society of Cardiology guidelines for management of elevated blood pressure and hypertension, if you remember, I said hypertension is blood pressure of 140/90. Elevated blood pressure is 120/139 over 70/89. So the recommended target systolic blood pressure for most adults receiving blood pressure lowering medication is 120/129. That is the target. It's just like saying people that are diabetic, what is the target HbA1c or what's the target fasting blood sugar? It doesn't mean that is what, it's not that target you use for diagnosis, but it is that target you use for patients that are on treatment. But there's a caveat to it, provided the treatment is well tolerated. However, for older adults, particularly those aged over 85 years, I mentioned earlier, those with significant frailty, and those that have low life expectancy, less than 3 years, you have no business tightening their targets to 120/129. What we need to do in such cases is to titrate the blood pressure to as low as reasonably achievable. It is called the ALARA principle, so that you don't cause side or adverse effects. As low as reasonably achievable. Patient is starting to have orthostatic hypotension, you want to be careful. You are not looking for a target of 120/129. Or patient is over 85 years. Please, let's do target of 140/90, which is still guideline recommended. So let's take note of the ALARA principle. We recommend the start low and go slow approach. Start with monotherapy or dual therapy and gradually increase their doses before you now even include the third one if it is necessary. So what are the factors influencing treatment in older adults? So for treating older adults, it's not so straightforward like treating younger people. We have to put so many things into cognizance in their treatment. It's this same older adult we've talked about orthostatic hypotension. We've talked about isolated systolic hypotension in them. So you need to be careful. And there are so many things that are surrounding them that you need to put into consideration, like their comorbid condition, because the comorbid condition they have will also determine the type of medication you want to give. If the person has comorbid diabetes, you want to make sure the person is on ARB or ACI. So the medical aspects, the other medical condition that this patient has is very important to consider. You want to see if the patient is frail. You want to see if there's polypharmacy. You want to see if there's malnutrition. These are all the things that needs to be assessed in an older adult before you determine the type of medication or the type of treatment to give them. You also want to consider their physical domain, their physical exhaustion, their gait, their daily living activities. Can they perform basic activities of daily living? Can they perform instrumental activities of daily living? If this person cannot perform BADL, cannot perform IADL, and especially when the person cannot do BADLs, you want to be careful with your antihypertensives so that you don't further depress the person. So you have to put into cognizance all these things. When you're looking at the physical domain, you're also looking at mobility. Is this person able to move around or not? Cognitive and depressive status. Dementia, delirium, depression, anxiety plays a major role for patient that is demented and does not have so much social support. The kind of drugs you have to give that person, you have to be really careful, or someone that is depressed, so that the person does not go and commit suicide or take medications that will further depress their cognition. We have to be careful in managing these patients, and it will influence the choice of medications we give them. Yes, we want to take care of their symptoms. They have so many symptoms here and there. Oh, I'm leaking urine. Before I get to the toilet, the urine comes out. You want to give drugs for overactive bladder. You want to give drugs for pain. My back is paining me. It goes to my leg. You want to give some anti-seizure medications that have neuropathic effect. All those things, they are very good, quite all right. But we have to put all these things into consideration before we decide the kind of medication. It's not just plug and play for older people like it is for younger adults. We have to put all these things into consideration. Their social status, their economic status. Can they afford the drug? Yes, the drugs are too many. There's polypharmacy. When the drugs are more than 5, we say there's polypharmacy. But then this person cannot afford single pill combination. Will you say because the patient cannot afford single pill combination, you will not treat the blood pressure that is 180/100? You will still have to give the medications because you want to keep this patient safe. So you have to consider all these things in your drug prescription. So factors to consider in initial treatment decision. So like I said earlier, patients that have CVD risk, you want to decide the kind of drug you want to give them. You might need to do ARB, you might need to give ARNI, you might need to give antiplatelets, you might need to give anti-cholesterol medication, depending on what you are faced with. So you are looking at this mnemonic: brace, benefit, risk, adapt, cost, ease for the patient. This is peculiar to older adults. You want to consider whether combination therapy is necessary for this person. The drugs are getting many. We're having 8, 9 drugs. Can I combine 3? 2, the patient is hypertensive, diabetic, has osteoarthritis, and has depression. By the time we count all the drugs might be just too many. So you want to see what is beneficial for this patient. So you need to consider all these things when initiating treatments for them. Drugs that have risk to them, especially that will go back to orthostatic hypotension, that have adverse side effects that can cause problems. You want to be careful with those medications. You have to consider it carefully before you give them, and you have to be mindful of polypharmacy. Adapt, which is part of the mnemonic for the brace. You adjust treatment goal and regimen based on comorbidities, frailty, and patient's preference. Like I said earlier, patient is frail, patient is more than 85 years, patient has low life expectancy, less than 3 years. You will not say it's by force, so I must do guideline directed treatments for these patients. Yes, that's why initially I talked about the guidelines, I talked about the current guidelines. It is important for us to know the current guidelines because it will guide our treatment. But at the same time, when it comes to older adults, we have to put brace into consideration. Sick day rules, somebody that has diarrhea and is on diuretic, you want to stop that diuretic at that time. The person needs to obey the sick day rule by discontinuing such medications at that time so that the person will not further go into more complications. Then you want to prioritize drugs. Don't say, it must be all this highfalutin. I don't want to mention any brand, and I don't want to encourage any brand. Nobody has paid me to advertise their brand. So we have to be mindful of cost. But for those that can afford it and we feel it's beneficial, why not? Also, save costs. Transport is very expensive these days. You can't keep saying come every 2 weeks. Patient is already stable on maybe your single pill combination. Give enough medications that can last 3 months. And they are so happy when you tell them they are doing well, I can see you in 3 months. Oh, doctor, you mean I don't have to come next month? They are so excited about it. So we have to consider costs in them and ease. I already talked about the single pill combination. We should prioritize the once daily dosing. It's always better than the multiple dosing for medications for our older adults because they can forget. Many of them have mild cognitive impairment or even severe cognitive impairment. So by the time you start saying you take this drug, TDS, 3 times a day, you're on your own, they probably will forget and just take it once a day. And when they come to the hospital, they tell you, doctor, I'm taking it. And as the physician, you feel as if you're taking TDS and you're still having this kind of blood pressure, let me go and increase. The next time you are hearing that mama collapsed and had a fall, on account of hypotension. So we have to be really careful. So we are going to getting to the end of the presentation. Age-friendly health systems. This is what is on board now in the care of older persons. What is age-friendly health systems? Age-friendly health system is an initiative from the Institute for Healthcare and Improvement. And it centers around 4 M's. These 4 M's are essential elements to provide holistic and person-centered care for older adults. What are these 4 M's? What matters? Medication, mentation, and mobility. Let's consider it. We'll see that it is very essential when we are managing older adults, not necessarily older adults with hypertension, for older adults generally, when we are assessing and managing them. What matters to this person is very important, because for some people, what you are treating does not even really matter to them. So you need to ask, what is priority? And as family physicians, for many of us that are family physicians on this call, we always assess or explore the patient's illness experience. And when you explore the patient's illness experience and you ask about their feelings, many of the time they will tell you what matters to them, so that you don't go ahead and start being aggressive about something that does not really matter to the older person that is 87 years or 90 years old. Sometimes what matters to them might be that I just want to maintain my independence. So you know that you focus all your care and treatments on making sure that this person is able to maintain his or her independence. Or, oh, what matters to me most, doctor, is this pain I feel. Meanwhile, you want to go and start treating the CAP, that's CA prostate. You want to go and start treating CA prostate. I had a patient. He was just 75 years old. For me, I still called him a young man. And he did a PSA that was high. And then I referred him to see the urologist. And the urologist said, with this high PSA, it was over 10, that it's likely you have prostate cancer. And the urologist wanted him to do a multi-parametric MRI of the prostate to be able to see if it was cancerous or not, to decide if they should do a biopsy. And the man came to me and was telling me that if he has prostate cancer, what are the options for him? So I was telling him, okay, there's drug treatment, they can do orchidectomy, remove his testes, or go ahead and remove the prostate. He said, God forbid, Sophia, it was an Easterner. He said, God forbid. So what's the essence of being alive if they will remove my testes? Then I'm not a man. There's no reason why I should be alive. That if that's the case, let him just leave it. That he would rather die than go and remove his testes, and he's not interested in doing prostatectomy. That if there's nothing else for them to do, then he doesn't even want to do the MRI at all, let alone know if he has prostate cancer or not. That let the cancer kukuma just kill him. For him, what matters is having his balls. He said, how will he be walking around and that place will be empty when they removed his testes? He said, no, God forbid. He would rather. I tried to explain to him that, no, okay, let's just do the MRI first. Then if the MRI is indicative, then we move on from there. What if it's not everything I was saying, he wasn't just hearing it. So at the end of the day, luckily for me, I started asking him questions. Okay, at the time you did the PSA, were you having dysuria and all that? For patients that have prostatitis, when they do PSA, the PSA usually goes up. So I said, okay, let's do this. Since you have refused to do this MRI, let's repeat your PSA and see. Let's assume that maybe because you had prostatitis at the time, that's why the PSA went up. And luckily for him, his PSA came down. And when he saw the urologist was like, okay, we'll repeat it again in 3 months. So he didn't have to. He said, thank God, though. But what, even if they had insisted, he wouldn't have done it. He would rather die with the prostate cancer rather than doing any surgical intervention. So for him, that was what matters, to move around with his balls. Some people is that, I don't want this erectile dysfunction. And you are saying, you must go and use this alpha blocker because your blood pressure is high. He said, the man will tell you, I will not use it. I've had patients like that, especially men. They will tell you, I will not use this drug. So as the physicians, we are supposed to help them find a way around it, especially when they are older adults. These are the things that matter to them. So you want to assess their medication. Is medication necessary? Are they age-friendly medication? You need to assess their mentation. They have dementia, depression, delirium. For all these things, there are tools we use in assessing them in geriatric clinic to assess their mentation, because this will determine what and how you want to treat them, because you cannot be treating a patient with depression for hypertension. It's not, the depression will probably not take the drugs. You need to address the depression first. Whether you are addressing it with medications or psychotherapy, you need to address it. Mobility. For some people, what matters to them is their movement. They want to be able to move around. So you need to assess these things. So you agree with me that if you assess all 4 M's, you would have really known about this patient and know the best way to manage this patient, and not just say, I'm following guidelines. So are we still there? I know it seems like I'm talking a lot. Please forgive me. Are we still listening? All right.
Yes.
So some recent advances in the management of hypertension. I won't dwell on them. I just thought we should mention it since we're talking about hypertension. ANI is not so recent anymore. It's very effective in the management of heart failure. The non-steroidal mineralocorticoid, we are used to spironolactone, but there are others that are better, newer ones, the non-steroidal ones that has reduced effect on hyperkalemia. There are other newer antihypertensives. Some of them can also be used in treatment of cancers. Then the device-based therapies, the renal denervation therapy I talked about, and the interventional cardiologist can use. I haven't seen all these things being done, but it is good for us to know that there are some advances in the management of hypertension. So we talked about the wearable devices. There are some cuffless blood pressure monitors these days. There are some mobile apps and AI algorithms. You are checking your blood pressure. Your doctor is seeing it where he is. We have telehealth, telemedicine, which is really helping in the management of this sect of people. Precision medicine, combination therapies, especially the single pill combination, has done wonders in helping us cope polypharmacy, especially in our older adults. Then lifestyle and nutraceuticals. Nutraceuticals are beginning to gain grounds. Nutraceuticals, like as something as simple as green tea, have been said to be helpful. Omega-3, all these supplements that we see around, even though for our older adults, we try to prescribe some of them, maybe leave just 1 or 2, but some of them have been shown to be beneficial. Then salt substitutes. Instead of sodium chloride salt, we use potassium chloride salt, and this has shown to be very helpful. I think in Lagos, if you go to all these organic stores, there's this potassium chloride salt called low salt that is very helpful. So it's a salt substitute. So instead of using your regular salt, if you use the salt substitutes, there is reduced risk of developing hypertension or reducing your blood pressure. Also, probiotics. Probiotics are beginning to do wonders from cradle to grave, from children to older adults. They are indicated in many disease conditions, including hypertension. It's not that you will say you will drop your antihypertensives and use probiotics. So, but in addition to probiotics, they've been proven to be helpful. We've talked about isolated systolic hypertension and other global initiatives that would help in the management of hypertension. It was just okay for us to mention some of these advancements in hypertension management. So in conclusion, take-home message. Hypertension is common in older adults, affecting 60 to 70% of individuals aged 65 years and above. It is a leading risk factor for stroke, heart failure, and kidney disease. Blood pressure targets should be individualized, especially in older adults. Even when you put into consideration the guidelines, you balance the benefits with the potential risk. And you also make use of your lifestyle modifications, which we've initially talked about. Engage patients in shared decision-making to ensure adherence to treatment plans. That's when you ask them what matters. Remember, we talked about the 4 M's. Address comorbidities and quality of life while minimizing polypharmacy risk. Managing hypertension in older adults isn't just about numbers. It's not about 140, 80, 150, 90 and all that. No, it's about reducing risk, which the ESC guidelines 2024 really talked about, improving outcomes and enhancing quality of life. These are my references. Thank you very much for listening. But I crave your indulgence if we can quickly look at this case study together so that we can bring together all that we have heard. You know, I've been talking. Sometimes you have all this knowledge here and there. But if we look at a case, we can harness everything that we have heard and put it into perspective. So let's look at this Mrs. EB. She was 80 years old. She presented with dizziness, fatigue for the past 1 month. She was diagnosed with hypertension 10 years ago. She's currently on amlodipine 10 milligrams daily, Moduretics 1 daily, including several over-the-counter pain medications, sleep aids, and supplements, which is not new to many physicians and even to the patients themselves that are listening. They always have these things. When they bring their brown bag or their nylon bag or poly bag or Ghana must go of drugs, you will see all this pain medication, sleep aids, and several supplements inside their bags. She reports frequent falls in the past 6 months, with 2 resulting in minor injuries, complaints of urinary urgency. That means before she gets to the bathroom, she's already leaking urine, and occasional incontinence. That means the urine just comes out without her knowing. She lives alone, but has support from her daughter for market shopping and medications. Cognitive decline was noticed by her family in the past year because she has been forgetting things and she has been missing appointments. Her past medical history: she's a known hypertensive, she has osteoarthritis, the knee pain, which is affecting her movement. She has mild cognitive impairment. Her social history: she's a retired school teacher.
What of the water?
Okay, this
Please,
one.
can someone help us mute the person that is unmuted?
Yes, please.
Okay, what else should I take? Take this?
So,
This is
her social history: she's a retired school teacher, she's widowed, she's socially isolated. Her blood pressure was 160/85 while sitting. And standing, it was 125/70. I know many people can echo it now after listening to this presentation. What does she have? She has orthostatic hypotension because we have greater than 20 millimeters of mercury reduction in systolic blood pressure and greater than 10 reduction in diastolic blood pressure, which puts her at orthostatic hypotension. She weighed 58 kg. She had lost 5 kg in the past year, which is an indication of frailty. Her gait is slow and unsteady. Remember, we said she has osteoarthritis and she has also lost weight, so she's now frail. Her mini mental state examination was 23/30, which puts her at mild cognitive impairment. Urinalysis was negative for infection. I know when I earlier said that she was having incontinence, she was having urgency, one would think she has UTI, but urinalysis was negative for infection. So for those of us that have listened to this study, to this case study, what do we feel? We can indicate by raising our electronic hands, or we can put in the chat box. I think the moderator can help me read the comments in the chat box. What are the problems? Maybe I should start with the non-medical people because it seems as if I'm talking to the medical people alone. For the non-medical people, what do you think, or what are the problems you can highlight from this case? I can go over it. You can carefully read the case study. What are the problems in this patient or in this Mrs. EB that we have seen? The problems we can pick out. We've talked about the medications, amlodipine, Moduretics, plenty drugs. She has been falling. She has urgency. She's leaking urine. She lives alone. She's forgetting things. So, I don't know. Is there anybody that wants to highlight some of the problems that we have noticed in this woman.
Please, you can drop your comments in the chat or raise your electronic hand if you want to make a comment. Thank you so much, ma.
Okay, somebody said loneliness. Yes, living alone at 80 years. Yes, serious, very serious problem. Yes, that's one of the problems. Is there any problems that we have highlighted from this case study?
There's another
Poor
comment.
cognition. Yes, poor cognition and living alone. Okay.
She also has incontinence. She has been having some kind of urge incontinence or something.
Yes. She has urge incontinence, possibly overactive bladder since urinalysis was negative for infection. Okay. What else? Okay, let's move on. So, assessing Mrs. EB, of course, we know she has, yes, polypharmacy, risk of falling, yes. And she has actually fallen. Significant difference between sitting and standing blood pressure. Yes, orthostatic hypotension. Very good. Thank you. So she has hypertension, but it is complicated by geriatric syndromes. So all these plenty things we are saying, all the fall, all the incontinence, they are all geriatric syndromes. So one of the assessments is falls and mobility issues. For our older adults, we don't really say diagnosis. We list out the problems because sometimes the problems may even fill one page. And if you want to give a pill for all the problems, you'll probably kill the patient with polypharmacy. So we have to highlight the problems. So some of the problems highlighted are falls and mobility issues, likely multifactorial due to orthostatic hypotension, which she has, knee pain, potential polypharmacy because of all the plenty drugs that she has. She has cognitive impairment, even though mild, because many mental states indicated that she had mild cognitive impairment with possible exacerbation from medications or vascular changes. Because she's hypertensive, she could have vascular dementia. Unintentional weight loss, which is suggestive of frailty or inadequate nutrition. Urinary incontinence, likely urge incontinence. So what would we like to do for this woman? Putting into consideration the 4Ms. Remember, 4Ms is what matters. Medications, mentation, mobility. If we are putting the 4Ms into consideration, which I said earlier that this is what is front burner now in managing older adults. We need to put these 4Ms into consideration. So if we put these 4Ms into consideration, what do we think we should do for this Mrs. EB? Anybody? What would we like to do for her? Okay.
You can type in the chat. If you don't want to speak, you can
Have a
type.
meeting with her family. Fantastic. What will the meeting with her family do? You would know what matters. Because she's there, you will not have a meeting with her family while she's not there. She will be there too, because you want to find out what matters to her. She's 80 years old. She does not need money. Oh, of course, she needs money, but she does not need excess money. What is she using excess money to do? Once she has a place to sleep and food to eat and shelter and some simple clothes to wear, she's fine. And particularly for Mrs. EB, let's see what matters to Mrs. EB. Yes, someone said it would help us point out where I was reading it. It would help us point out the problems as we work together to get the best. Okay, yes, thank you. So what matters to Mrs. EB is that she wants to be independent. She wants to be able to do things on her own, like her basic activities of daily living. She wants to be able to dress herself, eat herself, move around herself. She wants to be able to go to the toilet and clean after herself. Because, old with increasing age, sometimes it gets to the point where all these geriatric syndromes are all together. The person may not be able to do all these things without help, and the person becomes dependent. But what mattered to Mrs. EB is that she wanted to be independent, and she wanted to still be able to attend church programs. So as a physician, we need to make sure we put what matters to her into consideration. So the goals of care was to discuss with Mrs. EB and her daughter, who is her family, rightly said by the person that said we should have a meeting with her family. We wanted to prioritize reducing dizziness and preventing falls because she had had a couple of falls. And so because of that, we wanted to maintain our independence and set blood pressure target to less than 140/90. You can see that we did not do the 120 to 139 as guideline indicated, even though guidelines still told us that when there are risk factors like frailty, which this woman has, we should do 140/90. And orthostatic hypotension, which she also had. So we are not going to be looking at target of 120 to 129. Rather, we'll be doing target of 140/90. So for her medication, I just want us to move ahead since we spent a lot of time. So for our medication management, we decided to remove moderatic, which is implicated in the cause of our orthostatic hypotension. We said earlier that those drugs that are notorious for causing orthostatic hypotension, diuretics, especially diuretics like moderatic that has 50 milligrams of the diuretic property in it. So we want to take that one out first and foremost to lower the risk of orthostatic hypotension. We wanted to add an appropriate ARB, that's losartan, 50 milligrams daily, in addition to the amlodipine that she's taking for better blood pressure control. We said it earlier that ARBs have less effect on orthostatic hypotension. So we wanted to add ARBs to the calcium channel blocker she was already taking because it had fewer side effects. Then we reviewed all her medication for potential interactions or inappropriate drugs, like all the pain medications for the osteoarthritis and the sedatives. We first of all did the brown bag technique to tease out all those ones. And for assessing her mobility and fall prevention, we needed to address the orthostatic hypotension. And we have said earlier, in managing orthostatic hypotension, positioning matters. Rising slowly from a sitting or lying position, these are part of the education and counseling we gave. Increase hydration, and we told her to consider compression stockings. We referred to physiotherapy for gait and balancing training, and we recommended home safety modifications like having grab bars in the bathroom. For this woman that is frail, she needs something in the bathroom so she doesn't slip and fall. A lot of accidents that happen to older people, even for some younger people, happens in the bathroom. So we always want them to have grab bars in their bathroom, anti-slip carpets, which are these rubber carpets that will not allow them slip and fall. And also removal of some sleep hazards, even in the living room, when we have rugs that are not glued to the ground and can easily trip them, or so many clutters around the house. So we gave all that counsel about safety modifications in the house to prevent falls. You see, now I've not said that we are giving any particular medication for falls. All these counsel and education are parts of the management strategy to be able to handle this patient. For cognitive and nutritional assessment, a detailed cognitive assessment to rule out reversible causes of decline like vitamin B12 and TSH. We wanted to exclude B12 deficiency and hypothyroidism, which are also implicated in the cause of cognitive decline. We engage family in medication management to prevent missed doses. Also, we craved that she should get some community support to mitigate against social isolation. That's from neighbors, church members, since she liked church activities. So we craved the family to involve all these people around her since she was living alone. There was nothing we could do about her living alone since she was still independent, and we were trying to make her as independent as possible, because sometimes you can't really take care of all the problems. Sometimes we insist that, okay, don't live alone. Let somebody live with her. Yes, we'll say all that, but am I going to go and live with her? So we have to modify based on what is available. So we recommended her to be seen by the dietitian for nutritional optimization because of her weight loss. And we screened for depression and anxiety. She had some mild depression and anxiety, and we referred to the clinical psychologist for some psychotherapy. For our urinary symptoms, we did some trial behavioral strategies. That's for timed voiding and pelvic floor exercises, because we didn't want to give medications for overactive bladder, which she most likely had. Because when we add that one to it, those medications will also cause hypotension, dizziness, some cognitive impairments. Those are some of the side effects of all these our medications for overactive bladder. And she already has these things, so we didn't want to complicate it. So instead of giving her medications for that, we decided to do 2-hourly bathroom breaks, and we taught her pelvic floor exercises, which was helpful because she later said that the leakage of urine reduced. She wasn't leaking urine as much anymore, despite the fact that we didn't give medication. So it's always not all about medication. So the follow-up plan was to monitor blood pressure, orthostatic hypotension. That means we're checking her blood pressure, both sitting and standing, every 4 to 6 weeks initially. And we evaluated fall risk and gait improvements over time because we are sent for physical therapy. She was already seeing the physiotherapist. And so our gait has improved during the follow-ups. We explored non-pharmacological strategies for the sleep. Rather than giving a sedative, like I said, we don't give a pill for every complaint or for every problem. We did sleep hygiene, counseled on sleep hygiene, which I don't want to go into for this presentation today, but sleep hygiene is a very important component and always goes a long way in helping people that have difficulties with sleeping. Then we reassess medication efficacy and side effect at each visit. At each visit, we did the brown bag technique to look at the medication. Which one are you reacting to? Which one are you reacting? Which one have you added? Which one has Mama Sarah asked you to add? Because all those things happen. You see that he said, hey, it's my friend, my neighbor, my sister that asked me to add this one. So we look at everything at every clinic visit to make sure that we are not dealing with a problem that is arising from the medication. So thank you very much for listening. I will take questions now.
Thank you so much, Ma, for that very brilliant, apt, and lucid presentation. It was beautifully delivered. I have learned so much. I think there is not, I don't need to, I wanted to give a brief summary, but with the case presentation as well, there is no need for me to summarize. You have done everything and you have laid emphasis on the most important thing that we need to know. So we'll just move on now to the question and answer session and also comments. So this is now time for us to ask our questions, make comments. So you can just signify by raising your electronic hands, and I would call you as I see the hands go up. Thank you so much. Thank you, Ma. So I can see one hand up. Damilola Ayeni. Please, you can unmute, man, and ask your question. Thank you.
Thank you. Good evening, everyone. Good evening, Ma. Thank you so much, Dr. Oluwati, for this beautiful presentation. Personally, I really appreciate it. It was very lucid. In fact, the informations are things that, it's quite refreshing to just get to hear them again. And I think at this point, a little bit biased, geriatrics biased, because it was very nice. I have some couple of questions. I appreciate the fact that you ended it with the fact that, okay, we have to individualize the treatment at the end of the day. But then for this elderly, there are some that they will tell you, like I recently saw one and it claimed that, it's because of the white coat hypertension that's why his BP is elevated. However, when I considered his previous readings, even at home, it wasn't like they were still elevated, despite the fact that he's on medication. So, at what point, I mean, that's one of my questions now. At what point, even at white coat hypertension, at what point should we be strict with treatment, or let me say, initiate treatment for cases that are not yet on treatment? That's my first question. Then the second question is that very common too amongst the elderly and hypertensive patients in general. Some people will tell you that their doctors told them that they should stop their medication, because I know that at the end of the day, we know hypertension treatment is a lifelong management, and medication ought to be taken daily for the management or lifestyle modification and all that, or both. But sometimes some of them will tell you that they told me in the hospital not to. So I'm not like against it, but I just want to know what it's right, in order to maybe encourage the good behavior, and then to like maybe stop the one that is not so good. So is it really right for we practitioners to say that, okay, stop your medication or use it so days, and then don't use it on so days, or based on your reading, then you determine if you're going to, not use your medication? I've seen some people who even tell me that for 120/80, it's already very low, and they will not use their medication that is getting too low. And I will still try to tell them that, okay, this is what this BP is and whatnot. So please, I would like a clarification on that, even for the elderly. Like, what is really the benchmark? Even though I understand you already mentioned some other factors that we should put into consideration, but still, like, I feel there should still be a kind of things that we should use to judge it. So what should that be? That'll be my second question. And then my third question is for polypharmacy. A lot of elderlies too, I don't know if it's a kind of mindset thing that they have to be on some supplements. If they are not yet on supplements, then it seems like their treatment is not accurate or adequate enough. So, like, how do we go about it, and when should they stop it? I've seen someone that has osteoarthritis. She has been on calcium for like greater than 5 months, and she was still on it. And there are still side effects of this medication, and some of them have like 2 or 3 other supplements, which are very expensive. And they also kind of have this belief that, oh, this thing is very good for them. So, and they are still managing some other conditions. So how do we kind of, I will not say discourage, but how do we balance it out? The supplements, their medication, and just trying to reemphasize lifestyle and the impact of fruit and vegetables. I advocate for fruit and vegetables lifestyle. I even tell my parents personally that, okay, this supplement, yes, if you have the money, good. But if you do not have it, if your diet is good, then I don't think there's a need for that. But I want to clarify, since I have this opportunity, that in the place of eating fruits and vegetables, enough of fruit and vegetables, does it really surpass or takes the place of the supplements? Can we substitute it for the supplements? I hope my questions and my talks are not too much. Thank you so much once again, Ma. I really appreciate it.
What was the last question?
So the
That
last question
fruits and vegetables replace with supplements?
Yes, exactly. Thank you, Ma.
Okay. I would like to take all the questions so that I can answer them all at once.
Okay, Ma. Is there any other? There is no other hands up, and there is no question in the comments in the chat box. It's just what is in the chat box is just commendation and some compliments. Well delivered presentation, good lecture, lucid presentation. So I think you can go ahead and answer that question, Ma.
Okay. So Dr. Annie's first question was, when do you commence treatment in the elderly? So guideline recommendation, 2024 ESC guideline. You commence treatments, that's pharmacological treatments now, which I assume that's what you're asking, at blood pressure of greater than 140/90. If there are no other cardiovascular risk factors, you commence treatment at 140/90. And remember, we said you should start low and go slow. I think that's how I'm going to answer that question. The second question was, why do we ask patients to stop blood pressure medications? Or maybe another doctor say you should stop the blood pressure medication because you're already having blood pressure of 120/80. Remember that from the guidelines, we said that the blood pressure target, both for older adults and younger adults, is one systolic blood pressure of 120/129. That's the blood pressure target. If you have blood pressure going lower than this, you may want to titrate your medications lower, not stop the medication. You can want to change medications to medications that don't have so great an effect on blood pressure, not the ones that would rapidly reduce blood pressure. So we do not stop the antihypertensive treatment. We can reduce the dose. We can change it to more heart-compliant medications or whatever it is that is going on. You can play around the medications for the best interest of the patient. Remember, we'll do it, take the blood pressure as low as what is clinically achievable for that patient. Then the third question, you said supplements, how do we balance it? Yes, there are some supplements that are essential, especially calcium and vitamin D, because our older adults, especially women, are prone to developing osteopenia and osteoporosis. For those of them that have osteoporosis, they can be on lifelong calcium and vitamin D supplements. Many of them come with several other supplements that when you look at them, they almost contain the same thing. So what I usually do is to look at them and look at the one that contains maybe most of it and just pick one. Or ask, because a lot of times they don't even buy these things themselves. Their relative, friends, and children send these things to them from the abroad. And so that's why they have it so many. And then they use the same thing over and over again in different names and different labelings. So you can just help them to pick out one. But actually, when someone eats healthy, a balance between all your carbohydrates, proteins, fats, oil, water, minerals, and vitamins, you really don't need so much of these supplements. In the presentation, we talked about nutraceuticals, and some of those nutraceuticals are actually supplements, and some of them are helpful in reducing blood pressure. I did not say in treatments, they are used as additional treatments. So when the patient is on omega-3, well, it's fine by me. As long as you're not adding too many things to it, you can go ahead. You are on cod liver oil. It's okay. It's a nutraceutical. You can go ahead. So for we do not go against the supplements. We don't say, no, don't take it. We don't just want you to combine so many and now cause polypharmacy that will now start giving you some unnecessary side effect that will start wondering where the problem is coming from. So we deprescribe most of them and just leave a few essentials. Even your ginseng, green tea, cod liver oil, omega-3, all these things are nutraceuticals, and some of them are actually really helpful. So the last one is the fruits and vegetables. Well, I think I already answered that the fruits and vegetables replace the supplements. Yes, if you eat a balanced diet, you really don't need so much supplements anymore. I don't know if I was able to answer your questions, Dr. Ayeni.
Yes, ma. Thank you so much, ma.
Thank you for that beautiful response. Thank you so much for the presentation. I think we have come to the end of the presentation, so I'm going to hand over to Dr. B to go ahead, Dr. Ladujure to go ahead and make some comments towards the end. Go ahead, sir. You have the floor.
Thank you very much. Thank you very much, Ma, for the wonderful presentation. And I believe everyone on the call has gained a lot of knowledge from this presentation to be able to care for these people and to be able to advise appropriately. So on behalf of the Hypertension Awareness Forum, I want to appreciate your time. You can see that these have taken a lot of effort, days of preparation to be able to deliver this lecture, and we appreciate your effort. And I want to also appreciate as many of us that were able to give that time to join and wait this long on the call. I only have doctors, senior doctors in the house, and we also have people in the house that are members of the forum and also people that got to know or see the advert and join the call. We want to appreciate you very much for this, for the time that you are giving to us, and then we also want to advocate that as we have gained this knowledge, let's share the knowledge across our people, because especially at this time when the economy is down, the more preventive we can, the better for everyone. So let's be vanguard on hypertension. And this meeting holds every month. Next month, we'll be talking about hypertension in the young. Oh, let's be on the lookout. We see and also on the YouTube channel, we go there, we can see the past lectures we've had on stroke, on hypertension, and the heart, on treatment, the treatment of hypertension in the past, present, and future, and other hypertension red flags, and some other topics that we've had before. They are all on the YouTube channel that we can get. And then we also be on the lookout. We always advertise as much as possible our series of meetings. And if we feel we want to support the initiative, you can reach out to me personally. So thank you very much. We've had a long day. We want to round it up here. Thank you very much, everyone. See you next month.
Thank you.
Thank you and good night to everybody.
Good night. Thank you, Madam Moderator.
Thank you, Ma. Well done for a brilliant presentation again.
Diana, all of them, all the very best I did there. Okay, I think I can end the call now. Editors, have you seen it? I will remain there. Don't go finish. Yeah, let it trust. Dr. Richard. Chief, this one, just have a trouble. No, Dr. Richard, Dr. Richard, look out. Dr. Richard, good evening, sir. Many trust healthcare. I've replied you. Have you seen my message?
Yeah, thank you. Thank you. I got it, Dr. Bosie. Thanks a lot.
Yes, sir. Thank you, sir.
Every month you guys are on this, isn't it?
Yes, sir.
Okay, beautiful. What's the name of the association so that I can have it?
Hypertension Awareness Forum.
Okay.
Yes, sir.
Are you in Lasut? Are you in Lasut?
I'm in Lutz currently.
Okay. You're not just in Lasut, but in Luth.
I'm in Lutz now. Yes, sir.
Thank you very much. Thank you.
Thank you very much, sir.
Attention. Yes.
Awareness Forum. Yes, sir. I'll give you more details when we chat.
Okay.
I will send to you. Yes, sir.
Hypertension, that's what you do.
Yes. Hypertension related topics. Yes.
It's okay. Hypertension awareness
Yes, sir. Forum.
Okay. Beautiful.
Yes.
Very good. Very nice. Very nice.
Thank you very much, sir.
He came to give a lecture to our class of Luth alumni sometime.
Oh, okay, sir. Okay, sir. Thank you very much, sir. Yes, sir. Yes, sir. Bye, sir. Yes, sir. Thank you, sir. So, thank you, everyone. I think I want to end the call now. Mommy Wolan, I greet you. Mr. Rabiu, I greet you. Thank you all for coming. Mommy George, thank you for coming. I hope you're able to hear us.